In a time where the scalpel was a kitchen knife and the doctor was also the barber, what was the survival rate? Well, let's say you had some if you were praying. You were anesthetized with a sip of bad wine and had to hope the leeches would solve everything. But they didn't. Today I'm going to show you exactly why you wouldn't last even 5 minutes on a medieval surgical table, if you can even call that log a table. Subscribe and comment where you're from. Thank you. The good news is that medieval surgery was absolutely free of charge. No insurance forms, no co-pays, and no arguing with your provider about whether that amputation was really medically necessary. The bad news is that you'd be paying in ways that make modern healthcare bills look downright adorable. Think less arm and leg financially and more actual arm and actual leg physically. Medieval surgery was essentially a high-stakes game of operation, except the buzzer was your screaming, the tweezers were rusty, and the surgeon had probably spent the morning shoeing horses or cutting hair before pivoting to cutting you open. Let's be clear, medieval surgeons weren't incompetent by choice. They were operating, pun absolutely intended, in a world where germ theory was as foreign a concept as Netflix or indoor plumbing. These brave knife wielders were doing their best with what they had, which wasn't much beyond sharp objects, alcohol for them, not necessarily for you, and the firm belief that your illness was probably caused by an imbalance of bodily humors, or possibly a vengeful which who lived down the lane. The medieval medical community had a shockingly good understanding of anatomy, considering they were forbidden from dissecting bodies for centuries. This is like becoming a car mechanic without ever being allowed to look under a hood. You might know that an engine exists, but good luck figuring out which part makes the funny noise. Your surgical experience would begin with a diagnosis, typically conducted by a physician who considered himself far too educated and important to actually touch your disgusting, disease-ridden body. While modern doctors use stethoscopes and blood tests, medieval physicians preferred to diagnose you by examining a flask of your urine, called uroscopy, holding it up to the light, swirling it around, and sometimes even tasting it. Yes, tasting it. The next time you complain about a urine test, remember that at least your doctor isn't sipping it like a fine wine, commenting on its bouquet and notes of kidney failure with hints of impending death. Color charts for urine existed, with poetic names like white as well water or red as oriental saffron, proving that medieval marketing departments were working overtime even then. After diagnosis came preparation for surgery, which mostly involved making peace with your God rather than anything resembling modern preoperative care. No one would be checking your vitals or discussing anesthesia options, because anesthesia, as we know, it didn't exist. Instead, you might be given alcohol, opium, or mandrake root to dull your senses, though these were often reserved for the wealthy. For everyone else, there was the budget option, being bonked on the head just hard enough to knock you out, but not hard enough to kill you, a medical calculation that surgeons performed with all the precision of a drunk man throwing darts. Sometimes patients were simply held down by strong assistants, which means your surgical team included a few burly men whose job description was essentially professional person holder downer, a position that has sadly disappeared from modern operating rooms. Pain management in medieval surgery relied heavily on screaming. This wasn't just therapeutic for you. It was actually considered medically beneficial, as physicians believed pain could help expel bad humors from the body. Think of it as a medieval version of "this hurts me more than it hurts you," except it absolutely, unequivocally hurt you more. Some surgeons provided patients with leather straps to bite down on during procedures, which was less about compassion and more about not having to hear your shrieks echoing through the village and scaring away potential future customers. In particularly wealthy households, a musician might be hired to play loud music during surgery to drown out the screaming. History's first surgical soundtrack, centuries before surgeons would be blasting Eye of the Tiger while removing actual eyes or tigers. Your surgical environment would be nothing like the sterile operating rooms of today. Instead of a clean hospital with bright lights and beeping machines, you might find yourself on a kitchen table, in a barber's chair, or even on a tavern bench if your situation was particularly dire. Medieval surgeons were often barber surgeons, men who switched comfortably between trimming beards and trimming body parts. This dual profession made a certain economic sense. Both required sharp tools, steady hands, and customers who left looking dramatically different than when they arrived. The iconic barber pole with its red and white stripes originally represented bloody bandages wrapped around a pole, essentially medieval medical advertising saying, "Haircuts and bloodletting available here. 2-for-1 Tuesdays." Surgical instruments were horrifyingly basic by modern standards, though impressively diverse for the time. A medieval surgeon's toolkit might include various knives, saws, forceps, and probes, all made from materials like iron, silver, or bronze. The concept of sterilization hadn't been invented yet, so these tools would be wiped clean, maybe between patients, but certainly not disinfected. In fact, many surgeons took pride in their blood-encrusted instruments, seeing the accumulated gore as evidence of experience rather than as a mobile bacteria colony. Some tools had multiple uses. The same drill used to bore into a skull to release bad humors might later be used for woodworking, giving a whole new meaning to the phrase weekend DIY project. At least this meant medieval surgeons were environmentally conscious, following the reduce, reuse, recycle philosophy centuries before it became trendy. The surgical workforce of medieval times would make modern hospital administrators have an aneurysm. There are no board certifications, no malpractice insurance, and absolutely no standardized training requirements. Your surgeon might have learned his craft through a formal apprenticeship, or he might have just picked it up by watching other surgeons work, in a medieval version of learning surgery through YouTube tutorials. Women were generally excluded from formal medical training, although many worked as midwives and herbalists, often with more practical knowledge than their male counterparts who were busy debating whether your illness was caused by an excess of yellow bile or the position of Jupiter. The hierarchy was clear. Physicians were educated, respectable men who diagnosed diseases but wouldn't dirty their hands with actual treatment. Surgeons were considered craftsmen, somewhere on the social ladder between artisans and butchers, and nurses barely registered as medical professionals at all, despite doing most of the actual patient care. Medieval operating procedures would give modern surgeons nightmares, or possibly hysterical laughter. Take trepanation, for example, the practice of drilling or scraping a hole in the skull to treat ailments ranging from headaches to epilepsy to demonic possession. This procedure was performed with tools that looked like they belonged in a carpenter's workshop rather than a medical facility, and often without any anesthesia beyond a strong drink and a stronger prayer. Surprisingly, archaeological evidence shows that many patients survived this procedure, as indicated by skulls showing healing around the surgical holes. This means either medieval surgeons were better than we give them credit for, or the human body is remarkably forgiving of being treated like a home improvement project. Maybe both. Amputation was another common procedure, particularly necessary in a world where a simple cut could lead to fatal infection. A skilled surgeon could remove a limb in under a minute. Speed was essential when your patient was fully conscious and your anesthetic was a gulp of brandy. The process was brutally straightforward. Tourniquet the limb, cut through skin and muscle with a knife, saw through bone, and cauterize the stump with hot oil or a heated iron to prevent bleeding. This cauterization also served as a primitive form of sterilization. Though that wasn't the intent, they just knew it stopped the bleeding, not that it killed bacteria. The patient might then be given a wooden peg or crutch and sent on their way. Rehabilitation consisting mainly of try not to die from shock or infection. Medieval prosthetics range from simple wooden attachments to surprisingly sophisticated iron hands for the wealthy, though none came with the occupational therapy or physical rehabilitation we'd expect today. Bloodletting was perhaps the most common surgical procedure, used to treat virtually everything from fever to madness. Based on the belief that illness resulted from an imbalance of the four bodily humors, blood, phlegm, black bile, and yellow bile, physicians prescribed bloodletting to restore harmony. This could be done by cutting a vein, applying leeches, or using cupping, creating a vacuum on the skin to draw blood to the surface. The amount of blood removed could be substantial, sometimes up to 4 pints, about half the total blood volume of an adult. Patients often fainted during these procedures, which doctors took as a sign that the treatment was working, rather than as the body's way of saying, "Stop draining my life force, you medieval maniac." Leeches were so central to this practice that one medical practitioner, Gilles de Corbeil, wrote a 4,000-verse poem about urine and bloodletting, proving that medieval medical literature was just as thrilling as it sounds. Special surgical considerations existed for different social classes. If you were a peasant, your surgery might be performed by the local barber or even a blacksmith, using techniques passed down through observation and oral tradition. If you were wealthy, you might be attended by a university-trained surgeon, though his education consisted largely of reading ancient Greek and Roman texts rather than actual practical experience. Either way, you were in for a world of hurt, though the wealthy patient might at least get clean sheets and better pain management options. Royalty received the most dangerous care of all, with multiple physicians attending them, each afraid to contradict the others, and none willing to admit ignorance for fear of royal displeasure. King Charles II of England was reportedly treated for a seizure with treatments including bloodletting, cupping, enemas, blistering agents, sneezing powder, and having his head shaved and blistered with pigeon droppings, a combination approach that almost certainly hastened his death rather than preventing it. Post-surgical care in medieval times would make modern infection control specialists spontaneously combust with horror. Wound dressing typically involved materials like cobwebs, actually somewhat antimicrobial, though they didn't know that, moss or cloth soaked in wine, vinegar, or various herbal concoctions. Some of these had genuine medicinal properties. Honey, for instance, does have antibacterial qualities, but they were applied based on tradition rather than understanding of germ theory. The concept of changing dressings regularly wasn't standardized, meaning your surgical wound might be bound up and then left to fester until it either healed or killed you. Recovery took place at home rather than in a hospital, unless you were poor or a pilgrim, in which case you might recover in a church-run hospice where care was provided more for your soul than your body. Family members were your nurses, changing dressings and feeding you according to whatever instructions the surgeon had given, which probably included helpful advice like, wait and see if they live or die. Your surgical diet would be based on the theory of the four humors, with foods prescribed according to their supposed temperatures and qualities rather than nutritional content. If you survived surgery, you might be instructed to avoid foods that were considered cold or moist if your condition was already deemed cold and moist. This makes about as much sense as choosing your post-op meal based on your zodiac sign, but at least it gave patients something to think about besides their pain. Some post-surgical diets actually made sense. Clear broth for those with fever, for instance, while others were bizarrely specific, like avoiding fish and milk in the same meal after eye surgery, lest you go blind. Medieval medical recipes could include ingredients ranging from the mundane, garlic, which does have antimicrobial properties, to the mystical, powdered unicorn horn, which was usually narwhal tusk, to the downright disgusting, various animal excretions that we won't detail here, because you might be eating while reading this. Infection was the greatest post-surgical killer, though no one understood why wounds became infected. Without germ theory, surgeons attributed putrefying wounds to bad air, punishment from God, or the patient's unhealthy constitution rather than to the surgeon's unwashed hands and instruments. Some medieval medical texts described laudable pus, thick, white, sweet-smelling discharge from wounds that was considered a positive sign of healing rather than a raging infection. This is like celebrating mold on your bread as a sign that it's becoming penicillin rather than throwing it away like a sane person. Gangrenous limbs would be amputated, but systemic infections had no treatment beyond prayer, leading to mortality rates that would shut down any modern hospital faster than you can say medieval malpractice lawsuit. Pain management during recovery relied on herbs, alcohol, and prayer, often in that order as supplies of the first two ran out. Opium was known and used when available, derived from poppy plants and mixed into drinks called drowsy syrups. Willow bark, containing salicylic acid, the active ingredient in aspirin, was another effective option. Mandrake root could induce sleep but was dangerous to use, as the line between pain relief and permanent dirt nap was perilously thin. For the poor, pain relief might consist entirely of alcohol if they could afford it, or simply gritting their teeth if they couldn't. Medieval pain scales didn't exist. No smiley faces turning to frowny faces here. So patients expressed their pain through the time-honored tradition of screaming, moaning, or if they were English, saying, "It's a bit uncomfortable," while silently suffering agony that would make a modern person demand morphine administered through a fire hose. The concept of rehabilitation after surgery would have seemed absurdly luxurious to medieval patients. There were no physical therapists to help you regain strength and mobility, no occupational therapist to teach you how to adapt to your new limitations. If you survived an amputation, you figured out how to manage on your own or with family help, perhaps eventually acquiring a wooden peg leg or hook if you were lucky. The idea of getting back to normal wasn't really a consideration. Surgery fundamentally changed your life, and expectations were adjusted accordingly. Medieval guilds sometimes provided support for members who could no longer work in their trade due to surgical outcomes, an early form of disability insurance, though it generally amounted to "here's enough to not quite starve to death. Good luck." Success rates for medieval surgery were abysmal by modern standards, yet surprisingly good considering the limitations. Cataract surgery, for instance, involved pushing the clouded lens of the eye down into the eyeball using a needle inserted through the cornea, all while the patient was fully conscious. The fact that this sometimes actually improved vision is nothing short of miraculous. Surgeons developed genuine skill through experience, learning which techniques seemed to keep patients alive and which guaranteed a swift trip to the graveyard. Documentation of cases was rare, though some surgeons kept records of unusual cases or successful outcomes. One such surgeon, Guy de Chauliac, wrote a comprehensive surgical text in the 14th century that remained influential for centuries, despite recommending treatments like applying a mixture of earthworms, pigeon dung, and oil to wounds. Imagine writing a medical textbook so convincing that people follow your advice about putting worm-filled bird poop on open wounds for the next 300 years. The relationship between surgeons and patients was fundamentally different from today's informed consent model. Medieval patients had little understanding of what would be done to them and virtually no say in their treatment. Surgeons made decisions based on their training and experience, explaining little to patients beyond basic instructions. There was no concept of patient rights or medical ethics as we understand them. Surgeons were expected to at least try not to kill the patient, but beyond that, their obligation was primarily to their own conscience and reputation rather than to any external standard of care. This doesn't mean they were all callous butchers. Many genuinely wanted to help and felt the weight of responsibility for their patients' lives. But the framework for accountability simply didn't exist. If a surgeon had a string of patients die under his knife, he might face social consequences or loss of business. But there was no medical board to revoke his license, primarily because licenses didn't exist. Despite the gruesome reality of medieval surgery, there were medical pioneers who advanced the field in remarkable ways. Surgeons like Theodoric Borgognoni in the 13th century advocated for wound cleaning with wine, alcohol being antiseptic, and primary intention healing, closing wounds rather than keeping them open to suppurate. The Muslim physician Al-Zarawi wrote a 30-volume medical encyclopedia in the 10th century that included detailed descriptions of surgical techniques and over 200 surgical instruments, many of which he invented himself. Some of these innovations were remarkably advanced. Al-Zarawi described using catgut for internal stitches because it would dissolve naturally in the body, a technique still used in modified form today. These bright spots of innovation make the general brutality of medieval surgery all the more poignant. Glimpses of what could have been if only knowledge had been more widely shared and empirical observation valued over ancient textual authority. The mortality rate from medieval surgery is difficult to calculate precisely, but it was astronomical by modern standards. Amputation might have a 25 to 60% death rate, largely from blood loss or subsequent infection. Bladder stone removal, a relatively common procedure where a stone was extracted through an incision in the perineum, the area between the genitals and anus, have mortality rates ranging from 30% to 50%. Compare this to modern surgery, where even complex procedures have mortality rates often below 1%, and you start to understand just how brave or desperate medieval surgical patients truly were. To put this in modern terms, imagine going to a hospital where the waiting room is half filled with patients and half filled with coffins, just to keep things efficient. The surgeon greets you with, "Don't worry, I've done this dozens of times, and almost half my patients survived," and you're expected to respond with grateful tears rather than running screaming into the night, which would be any sane modern person's reaction. Demographics played a significant role in surgical outcomes, though not in ways that would make a modern statistician happy. Children had particularly poor outcomes due to their smaller blood volumes and inability to communicate symptoms clearly. Women faced additional dangers related to gynecological and obstetric surgeries, performed exclusively by male surgeons who had often never been permitted to examine a female patient before operating on her. Cesarean sections were almost universally fatal for the mother, performed only when she was dead or dying in an attempt to save the child for baptism. The elderly fared poorly as well, their reduced resilience making recovery from surgical trauma unlikely. The healthiest candidates for surgery were young adult men, the same demographic that most often needed surgery for battle wounds, creating a grim natural selection where those most likely to need surgery were also those most likely to survive it. If medieval surgery had a marketing slogan, it would have been something like, "Medieval surgery, your chances aren't good, but they're better than nothing." Slightly, the surgical facilities of the medieval period would make modern hospital administrators develop spontaneous stress ulcers. Forget sterile operating rooms with laminar airflow systems and specialized lighting. Your surgery might take place in the surgeon's home, a tavern back room, or even outdoors if the weather was favorable and the stench became too overwhelming. Hospitals did exist, but they functioned more as hospices for the dying or shelters for the poor than as medical treatment centers. These institutions, usually run by religious orders, had wards with multiple patients sharing not just rooms, but often beds, creating perfect conditions for cross-contamination and infection spread. Privacy was non-existent. Your surgery might be witnessed by other patients, apprentices, or curious bystanders who viewed medical procedures as a form of educational entertainment. Imagine going in for appendix removal today and finding yourself surrounded by a crowd of strangers eating popcorn and taking notes, and you'll begin to appreciate the medieval surgical experience. Lighting for surgical procedures relied on windows or candles, meaning complex surgeries needed to be performed during daylight hours or risk additional complications from poor visibility. This created a seasonal aspect to surgical practice, with more difficult procedures scheduled during summer months when days were longer and the surgeon had a fighting chance of actually seeing what he was cutting. Operating tables were typically wooden and porous, soaking up blood and bodily fluids from generations of patients. Some surgeons operated with the patient seated in a chair rather than lying down, particularly for procedures like tooth extraction or cataract surgery, where keeping the patient upright was mechanically advantageous. Temperature control consisted of, is there a fire in the hearth or not, with no concept of maintaining specific temperatures for patient safety. In winter, the risk of hypothermia during surgery added yet another potential complication, while summer heat brought flies and accelerated decomposition of surgical waste, creating a no-win situation regardless of season. Surgical hygiene practices range from non-existent to accidentally effective. Surgeons didn't wash their hands between patients, but some did wash their hands before eating lunch, inadvertently reducing transmission of some pathogens. Surgical gowns, as we know them, didn't exist. A surgeon might wear an apron to protect his clothes from blood, but this was about preserving his wardrobe, not preventing infection. These aprons were rarely washed, accumulating layers of dried blood and bodily fluids that would make them stiffen over time, creating the medieval equivalent of biological body armor. Some surgeons took pride in their blood-encrusted aprons, seeing them as evidence of experience rather than as mobile petri dishes. The concept of a sterile field existed only in the realm of fantasy, along with unicorns and politicians who keep campaign promises. Instruments might be wiped clean on the surgeon's apron between patients, but the idea of sterilization wouldn't emerge until the 19th century. Waste management during surgery consisted primarily of the floor, with perhaps a bucket for larger pieces of discarded tissue or amputated limbs. Blood was allowed to drain wherever gravity took it, sometimes through purposely made channels in the operating table. Contamination from previous procedures was a constant but unrecognized threat, with operating spaces rarely cleaned beyond sweeping out visible debris. Amputated limbs and removed tissues were typically buried, burned, or in some cases fed to dogs or pigs. Medieval recycling at its finest. Hospital waste might be dumped into the same rivers that provided drinking water, creating a perfect disease transmission cycle that kept surgeons in business. The concept of biohazardous waste didn't exist, though some cultures did recognize that decaying matter could cause illness, attributing this to miasma, or bad air rather than to bacteria or viruses. The smells of a medieval operating room would overwhelm even the strongest modern stomach. Without antiseptics, the predominant odors were blood, bodily waste, and infected wounds, creating a miasma that modern noses, accustomed to the sharp, clean scent of hospital disinfectant, would find unbearable. Surgeons worked through these odors without face masks or ventilation systems, becoming desensitized to smells that would send modern medical professionals racing for the nearest exit. Some attempted to combat the worst stenches by carrying pomanders, perforated containers filled with aromatic herbs and spices, or positioning their procedures near fires burning fragrant woods. These measures did nothing to reduce infection rates, but did make the experience marginally less nauseating for everyone involved. Patients who survived surgery often reported the smells as among their most traumatic memories, which is really saying something considering they'd just experienced someone cutting into their body while they were awake. The soundscape of medieval surgery was equally horrifying, a symphony of screams, moans, saw blades grinding through bone, and the surgeons running commentary. Without effective anesthesia, patients' vocalizations provided an audible indicator of their condition, with surgeons sometimes judging the success of their procedure by the changing pitch and intensity of screams. Silence was a bad sign, potentially indicating that the patient had lost consciousness or died. Surgeons might chatter throughout the procedure, discussing technique with apprentices or attempting to distract the patient with conversation, creating a bizarre social dynamic where the surgeon made small talk while the patient screamed in agony. Some wealthy patients hire musicians to play during their surgeries, hoping the music would drown out their own screams and provide some psychological distance from the procedure. This practice gave new meaning to the concept of mood music and created the world's most challenging performance venue for medieval musicians. The surgeon's appearance and demeanor would be jarring to modern patients accustomed to scrubbed, masked medical professionals. Your medieval surgeon would operate in everyday clothing, perhaps with an apron, his hands unwashed, and his beard unrestrained. No hairnets or beard covers here. The profession attracted individuals with strong stomachs and steady hands, but not necessarily compassionate bedside manners. Some surgeons developed psychological defense mechanisms to cope with causing pain, becoming brusque or detached with patients. Others drank alcohol before difficult procedures, ostensibly to steady their nerves, but more likely to dull their own psychological discomfort at the suffering they were about to inflict. Speed was prized above precision, with the best surgeons able to amputate a limb in under a minute, a skill that prioritized reducing the duration of unbearable pain over ensuring clean cuts or preserving maximum function. This created a surgical style more akin to a carpenter rapidly sawing through lumber than the meticulous, unhurried approach of modern surgery. Record keeping for surgical procedures ranged from rudimentary to non-existent. The concept of a standardized medical chart hadn't been developed, so information about previous treatments, allergies, or complications wasn't readily available. Some surgeons kept personal notes about interesting cases or successful techniques, but these were for their own reference rather than for patient care. This meant that if you required multiple surgeries, each one essentially started from scratch, with no systematic way to learn from previous interventions. Patient identification relied on personal recognition rather than wristbands or charts, creating obvious problems in busy hospitals or when patients were unconscious. Surgical outcomes were tracked anecdotally rather than statistically, with surgeons remembering their successes and conveniently forgetting their failures. This made it nearly impossible to determine which techniques were actually effective and which were merely traditional, hampering progress and innovation in the field. The distinction between necessary and elective surgery barely existed in medieval times. Without advanced diagnostic techniques, surgeons relied on visible symptoms, patient descriptions, and their own experience to determine whether intervention was needed. This led to both undertreatment of internal conditions that couldn't be seen and overtreatment of visible conditions that might have resolved on their own. Cosmetic surgery existed primarily for reconstructive purposes, particularly for facial wounds from battle or accidents. These procedures could be surprisingly sophisticated, with techniques developed to repair lips, noses, and ears using tissue flaps. Though without anesthesia or antibiotics, the suffering involved would make modern cosmetic surgery patients faint at the thought. The idea of surgery for purely aesthetic enhancement would have seemed absurdly risky to medieval patients, who understood that any surgical procedure carried a substantial risk of death. The concept of surgical specialization was in its infancy during the medieval period. While some practitioners became known for particular procedures, like cutting for bladder stones or couching cataracts, most surgeons were generalists by necessity, expected to handle everything from tooth extraction to amputation. Specialization was limited by the overall scarcity of surgical practitioners and the economic reality that most couldn't make a living performing only one type of procedure. The exception was battlefield surgery, where some surgeons developed considerable expertise in trauma management through sheer volume of cases, becoming medieval versions of combat medics. These battlefield surgeons sometimes pioneered techniques that later entered civilian practice, just as modern military medicine often advances civilian care. The difference, of course, was that medieval battlefield innovations weren't subjected to clinical trials or peer review before being adopted. They simply moved from one bleeding patient to the next. Surgical instruments were handed down through generations, their designs changing little over centuries. A medieval surgeon might use tools virtually identical to those used by Roman surgeons 1,000 years earlier, with innovations and improvements spreading slowly in a world without professional journals or conferences. Some instruments were multi-purpose. The same knife might be used for lancing boils, opening abscesses, and amputating fingers, with perhaps a quick wipe on the surgeon's apron between uses. Instrument maintenance consisted of basic cleaning and sharpening, with no concept of sterilization beyond perhaps wiping with vinegar or alcohol, which did have some antimicrobial effect, even if the reason wasn't understood. Surgeons were often possessive of their instruments, seeing them as extensions of their skill and closely guarded professional assets. A surgeon's death might be followed by the ceremonial passing of his instruments to apprentices or colleagues, creating a lineage of tools that carried both practical knowledge and symbolic weight. Your chance of surgical survival depended greatly on your surgeon's training and experience, which varied wildly across medieval Europe. In some regions, surgeons were university trained, with formal education in anatomy and surgical techniques, albeit based largely on ancient texts rather than practical experience. In others, they were essentially skilled tradesmen who learned through apprenticeship, developing practical skills without theoretical understanding. The division between academic surgeons and craft surgeons created tension within the profession, with each group claiming superiority. Academic surgeons had better theoretical knowledge, but sometimes less practical experience, while craft surgeons had extensive hands-on experience, but might lack understanding of why certain techniques worked. This dynamic created a medieval version of the modern tension between evidence-based medicine and clinical experience, though both forms of medieval evidence would be considered woefully inadequate by modern standards. Religious considerations profoundly influenced medieval surgery in ways that modern patients would find both bizarre and occasionally harmful. The Catholic Church's prohibition on human dissection, based on the belief in bodily resurrection, severely limited anatomical knowledge. When dissections were permitted, typically of executed criminals, and only a few days per year, they were conducted as public spectacles, with a professor reading from Galen's ancient texts while a barber surgeon performed the actual cutting. Since Galen had based his anatomical descriptions on animal dissections rather than human bodies, the professor would often be describing structures that simply didn't exist in a human specimen, creating a surreal disconnect between text and reality. Rather than questioning the ancient authority, observers would typically assume the body was abnormal or that they were failing to identify structures correctly. A medieval version of "Who are you going to believe? This revered ancient text or your own lying eyes?" Supernatural explanations competed with natural ones for understanding surgical outcomes. A successful surgery might be attributed to divine intervention or the intercession of a particular saint, while surgical failures were often seen as God's will or punishment for sin rather than as technical errors or infections. Patients would pray to saint specialists before surgery. Street Agatha for breast diseases, Saint Blaise for throat ailments, Saint Lucy for eye problems, creating a pantheon of medical patron saints who specialized more narrowly than modern medical consultants. Surgeons themselves might incorporate religious elements into their practice, making the sign of the cross before beginning or reciting prayers during difficult moments. Some surgical instruments were inscribed with religious symbols or text, turning them into both medical tools and objects of faith. For patients, this religious dimension provided psychological comfort in the absence of effective physical interventions, giving meaning to suffering that otherwise seemed random and cruel. The medieval understanding of the relationship between physical and spiritual health created unique challenges for surgeons. The body was seen not just as a biological system, but as a reflection of moral and spiritual status, with physical ailments potentially indicating spiritual problems. This meant that surgery sometimes required coordination with religious authorities, particularly for conditions thought to have supernatural causes. Epilepsy, for instance, was often viewed as demonic possession rather than a neurological disorder, leading to treatments that combined physical interventions like trepanation, drilling holes in the skull, with spiritual remedies like exorcism. This integrated approach made sense within the medieval worldview, but created obvious problems when physical conditions were misattributed to spiritual causes or vice versa. Imagine going to a modern hospital with appendicitis and being told you need both surgery and a stern talking to from the hospital chaplain about your moral failings, and you'll understand the medieval patient's experience. Gender played a complex role in medieval surgery, creating barriers and opportunities that shaped the field for centuries. Women were largely excluded from formal surgical training, but many practiced as midwives, bone setters, or tooth drawers, developing considerable practical skill despite their lack of official recognition. Female practitioners typically focused on treating other women, particularly for gynecological and obstetric conditions that male surgeons were often prohibited from handling directly due to modesty concerns. This created the bizarre situation where male surgeons wrote authoritative texts about female anatomy and childbirth based primarily on theory and secondhand accounts rather than direct observation. Some male surgeons refused to look at female patients' bodies at all, examining them by touch alone or having the patient point to corresponding areas on a doll or diagram. A practice that makes modern gynecological care seem refreshingly straightforward by comparison. The social status of surgeons varied widely across medieval Europe, influencing everything from their training to their compensation. In southern Europe, particularly Italy and parts of Spain, surgeons could achieve considerable prestige, sometimes rivaling physicians in status and education. In northern Europe, surgeons were more typically viewed as craftsmen, grouped with barbers and bathhouse keepers in guilds rather than with university-educated medical practitioners. This status differential affected how surgeons practiced, with higher status surgeons more likely to specialize in prestigious procedures like cataract surgery or facial reconstruction, while lower status practitioners handled routine procedures like bloodletting and tooth extraction. The association between barbers and surgeons persisted for centuries, with the barber-surgeon remaining a common figure well into the Renaissance. The distinction between surgeon and physician created a professional hierarchy that continues to influence medical culture today, though the relative status of the two has largely reversed, with surgical specialties now among the most prestigious and highly compensated in medicine. The economics of medieval surgery created a system that modern patients would find both familiar and disturbing. Like today, there was a multi-tiered system where wealthy patients received better care than poor ones. But unlike today, this differential was openly acknowledged rather than obscure behind insurance terminology. Wealthy patients might be treated in their homes with the best available pain management, while poor patients made do with charity care in hospital wards or marketplaces. Surgeons typically charged according to the procedure and the patient's ability to pay, sometimes accepting payment in goods or services rather than currency. Some surgeons offered payment plans or sliding scales, recognizing that their market included patients of varying means. Charitable organizations, particularly religious orders, provided surgical care for those who couldn't pay, though the quality of this care varied tremendously. Some medieval hospitals established by wealthy patrons provided surprisingly good care for the time, while others were little more than warehouses for the dying poor. The psychological aspects of medieval surgery were surprisingly sophisticated despite the brutality of the procedures themselves. Surgeons recognized the importance of the patient's mental state before and during surgery, with some practitioners developing techniques to reduce fear and build confidence. The surgeon's demeanor was considered crucial. A confident, authoritative manner was thought to improve outcomes by inspiring patient trust, a belief that continues in surgical culture today. Some surgeons deliberately cultivated reputations for miracle cures or special skills, creating medieval versions of surgical branding and marketing. Patient testimonials were valued, with successful cases serving as walking advertisements for the surgeon's abilities. Psychological preparation might include religious rituals, family gatherings, or the drafting of wills and settling of affairs, acknowledging the very real possibility that the patient wouldn't survive. This comprehensive approach to the psychological dimensions of surgery was in some ways more integrated than modern surgical care, which sometimes treats the mind and body as separate entities despite overwhelming evidence of their interconnection. The boundaries of medieval surgery were constantly negotiated between surgeons, physicians, barbers, and various other practitioners, creating turf wars that would seem familiar to modern medical specialties. Physicians claimed authority over internal conditions, leaving surgeons to handle external problems, a division that made less sense as knowledge of anatomy improved. Some procedures fell into gray areas, claimed by multiple practitioners. Bloodletting, for instance, might be performed by physicians, surgeons, or barbers depending on the region and the patient status. These professional boundaries were enforced through guilds, which regulated training, practice standards, and competition within their jurisdictions. Guild regulations sometimes protected patients by ensuring practitioners had at least basic competence, but they also restricted innovation and protected established practitioners from new competition. The tension between established authority and innovative outsiders shaped the development of surgery, with some of the most important advances coming from practitioners who operated at the margins of official recognition. Battlefield surgeons, empirics working outside guild structures, or practitioners from minority communities who developed parallel traditions outside the mainstream. The geographical variations in medieval surgery created a patchwork of practices across Europe, with significantly different approaches depending on region and cultural influences. The medical traditions of Al-Andalus, Muslim Spain, and Sicily were heavily influenced by Islamic medical knowledge, which included sophisticated surgical techniques, detailed anatomical understanding, and a more empirical approach than was common in Christian Europe. Northern European surgery was more typically rooted in folk traditions and practical experience, with less theoretical foundation. These regional differences meant that a patient might receive dramatically different treatment for the same condition depending on where they lived. A patient with a bladder stone in 12th century Cordoba might benefit from sophisticated lithotomy techniques and opium-based pain management, while a patient in 12th century London might face a much cruder procedure with minimal pain control. This geographical lottery was as significant for surgical outcomes as any other factor, creating dramatic disparities in care quality based simply on where a patient happened to live. The role of medieval surgeons during epidemics reveals both the limitations of their knowledge and their remarkable courage. During plague outbreaks, surgeons were often called upon to lance the buboes, swollen lymph nodes, characteristic of bubonic plague, a procedure that offered limited benefit to patients but exposed the surgeon to almost certain infection in an era before gloves or masks. Some surgeons fled along with physicians when epidemics struck, but others remained, seeing patient care as a moral obligation despite the personal risk. The plague doctor's costume, with its characteristic beaked mask filled with aromatic herbs, was a medieval attempt at personal protective equipment. Based on the miasma theory, the disease spread through bad air rather than person-to-person contact. While completely ineffective against bacterial transmission, this costume represents an early recognition that disease could be transmitted between individuals and that barriers might provide protection, a medieval precursor to modern infection control practices. The willingness of some surgeons to remain at their posts during epidemics, knowing the likely fatal consequences, represents a tradition of medical courage and sacrifice that continues in modern responses to infectious disease outbreaks. Cross-cultural exchanges in medieval medicine created unexpected bright spots in an otherwise grim surgical landscape. The Islamic world preserved and expanded upon Greek and Roman medical knowledge during Europe's Dark Ages, developing surgical techniques and instruments that were centuries ahead of their Christian counterparts. Physicians like Al-Zarawi, known in Latin as Albucasis, wrote detailed surgical manuals describing procedures and specialized instruments that wouldn't be matched in European practice for hundreds of years. When these texts were eventually translated into Latin, they revolutionized European surgery, introducing techniques like using animal gut for internal stitches, catgut sutures, that would dissolve naturally in the body. The Crusades, despite their brutality, facilitated medical knowledge exchange, with European surgeons returning home having observed superior Islamic medical practices. This represents perhaps the only time in history when going to war actually improved healthcare rather than just creating more patients for it. The development of surgical instruments shows both the ingenuity and the limitations of medieval medicine. While modern surgical tools are designed for specific procedures with ergonomic handles and standardized materials, medieval instruments reflected the technological constraints of their time. Many were multi-purpose, with the same basic knife serving for various cutting procedures with perhaps slight modifications. Specialized tools did exist, however, particularly for common procedures like bladder stone removal or cataract surgery. The cataract needle, for instance, was a slender instrument used to push the clouded lens down into the eye, temporarily restoring some vision. Trepanation required specialized drills and saws for cutting through the skull without penetrating the brain. At least, that was the goal, though the absence of depth gauges made this a matter of skill and luck. Some surgeons crafted their own instruments to address specific challenges, creating custom tools that died with them when they failed to document their innovations. Medieval ideas about antisepsis were inadvertently effective in some cases, despite the complete lack of understanding about germ theory. Wine and vinegar were commonly used to clean wounds, not because anyone understood their antimicrobial properties, but because they were thought to balance humors or counteract poisons. Hot oil was poured into wounds, particularly gunshot wounds, based on the theory that gunpowder poisoned the tissue, a horrifically painful practice that nonetheless sometimes prevented infection through heat sterilization. Honey was applied to wounds, not because anyone understood its antibacterial properties, but because it was observed to prevent putrefaction. The use of moldy bread on wounds, documented in some folk traditions, may have inadvertently delivered primitive antibiotics centuries before Fleming discovered penicillin. These practices worked through luck rather than understanding, but they demonstrate the empirical wisdom that sometimes developed even within flawed theoretical frameworks. The medieval understanding of surgical shock would be unrecognizable to modern medical professionals. When patients collapsed during surgery, it was variously attributed to fear, pain, blood loss, or the sudden release of vital spirits from the body. Without the concept of blood pressure or understanding of the autonomic nervous system, surgeons recognized the phenomenon but couldn't explain it accurately. Some surgeons developed practical approaches to managing shock, even without understanding its physiological basis, keeping patients warm, elevating their feet, or administering stimulants like wine or vinegar. The medieval approach to preventing shock focused primarily on speed, completing procedures as quickly as possible to minimize blood loss and pain. This created a surgical style that prioritized rapidity over precision, with the best surgeons able to complete amputations in under a minute. Modern surgeons trained to take their time and prioritize precision would be horrified by this approach. But in a world without anesthesia or blood transfusions, it represented a rational response to the constraints of the time. Surgical complications were explained through a combination of humoralism, religious frameworks, and empirical observation, creating an approach to postoperative care that was part medicine, part spirituality, and part superstition. Fever following surgery wasn't recognized as infection, but might be attributed to an imbalance of humors, requiring treatments like bloodletting that further weakened already compromised patients. Wound infection might be seen as the natural ripening of the wound rather than a complication, with pus formation considered a necessary part of healing rather than a sign of trouble. When complications proved fatal, surgeons had ready explanations that protected their professional reputations. The patient's constitution was too weak, their humors too imbalanced, or divine will had intervened. These explanations shifted responsibility from the surgeon's technique to factors beyond human control, creating a system where practitioners could maintain confidence despite high failure rates. Medieval patients accepted these explanations not out of ignorance, but because they aligned with the broader cultural understanding of how the world worked. The surgeon's toolkit for managing surgical complications was severely limited but not entirely ineffective. For postoperative bleeding, techniques included applying pressure, cauterizing with hot irons, or using styptic powders containing ingredients like alum or copper sulfate that actually did help coagulation. Infection might be treated by draining pus, applying poultices of herbs with antimicrobial properties, or in severe cases, amputating the affected limb before the infection spread. Pain management relied on opiates when available, alcohol when affordable, and endurance when neither was an option. Herbal remedies containing natural salicylates related to aspirin or other anti-inflammatory compounds provided some relief, though their preparation and dosage varied widely. Without understanding the mechanisms of action, surgeons relied on traditional formulations passed down through generations, creating an empirical pharmacopoeia based on observed effects rather than chemical understanding. Some of these traditional remedies have since been validated by modern pharmacology, containing active compounds that do indeed have medicinal properties. The medieval surgical patient's experience was shaped not just by physical pain, but by the cultural and religious frameworks that gave meaning to suffering. Pain wasn't viewed simply as a biological phenomenon to be eliminated, but as a spiritual experience with potential redemptive value. Christian theology linked suffering to Christ's passion, suggesting that pain endured with faith could have spiritual benefits, reducing time in purgatory or demonstrating devotion. This didn't mean medieval patients wanted to suffer. They absolutely used whatever pain management was available, but it did provide a framework for understanding unavoidable pain as meaningful rather than merely senseless. Surgeons sometimes incorporated this understanding into their practice, encouraging patients to offer up their suffering in prayer or to contemplate religious images during procedures. Modern pain management focuses exclusively on elimination or reduction of pain, but the medieval approach acknowledged that when pain couldn't be prevented, finding meaning in it could provide psychological resources for endurance. Medical education for surgeons varied dramatically across medieval Europe, creating vast disparities in knowledge and skill. In the Islamic world and parts of southern Europe influenced by Islamic medicine, surgical training could be remarkably sophisticated, with formal study of anatomy texts, observation of procedures, gradual assumption of responsibility under supervision, and examination before independent practice was permitted. In Northern Europe, training more typically followed the guild model, with apprentices learning through observation and practice under a master surgeon, often starting with simple procedures like bloodletting before progressing to more complex interventions. The quality of training depended entirely on the knowledge and skill of the master, creating a system where excellent techniques and dangerous errors were equally likely to be passed down through generations. Some surgeons supplemented practical training with formal study of anatomy and medical texts, but many practiced based entirely on apprenticeship experience and oral tradition, never reading a medical text in their lives. The disconnect between academic medicine and surgical practice created a peculiar situation where those who performed surgery often weren't those who wrote about it. University-trained physicians wrote sophisticated surgical texts based on ancient authorities and theoretical understanding, but might never actually perform the procedures they described. Meanwhile, practicing surgeons developed considerable practical skill through experience, but often lacked the literacy or theoretical framework to document their innovations. This divided medical culture limited progress, with practical advances failing to inform theory and theoretical insights failing to reach practitioners. The rare individuals who bridged this gap, university-educated surgeons who actually practiced regularly, were responsible for some of the most significant advances in medieval surgery. Guy de Chauliac, for instance, combined scholarly knowledge with extensive practical experience to write influential surgical texts that remained authoritative for centuries, representing an integration of theory and practice that was unfortunately rare in medieval medicine. Legal and ethical frameworks for surgical practice were rudimentary by modern standards, but not entirely absent. Some regions required surgeons to be licensed by guilds or universities, creating at least minimal standards for training and practice. Surgeons could be held liable for deaths resulting from obvious negligence or incompetence, though proving such cases was difficult in an era when many patients died despite the best available care. The concept of informed consent didn't exist as we understand it today, but surgeons generally did explain procedures to patients before beginning, if only to ensure cooperation during the ordeal. Ethical considerations focused more on the surgeon's moral character and intentions than on specific practices or patient rights. A good surgeon was one who acted with compassion, avoided unnecessary interventions, and charged fairly according to the patient's means, rather than one who followed specific procedural guidelines or obtained documented consent. This person-centered rather than process-centered approach to ethics created a system highly dependent on individual virtue, with patients essentially gambling that their surgeon was not just skilled but morally upright. The speed of innovation in medieval surgery was glacial by modern standards, with techniques remaining largely unchanged for centuries. Without systematic documentation of outcomes, statistical analysis, or controlled trials, surgeons had no reliable way to determine whether modifications to traditional techniques actually improved results. Innovation typically occurred through individual experimentation, with surgeons making small adjustments based on their personal experience. These innovations might spread locally through apprenticeship networks, but rarely reach the broader surgical community unless documented in texts, which most practicing surgeons never wrote. Major advances often came from outside traditional European practice, through cross-cultural exchange with Islamic medicine or Byzantine traditions. The translation of Arabic medical text into Latin in the 12th and 13th centuries introduced European surgeons to techniques and instruments that had been common in the Islamic world for centuries, representing one of the most significant knowledge transfers in medical history. This pattern, where innovations from one medical tradition took centuries to reach others, created a surgical landscape where a patient might receive dramatically different care depending not just on their location, but on whether their surgeon happened to have access to particular texts or training lineages. The role of medieval surgeons in warfare created a paradoxical situation where violent conflict actually advanced medical knowledge. Battlefield surgeons faced a volume and variety of traumatic injuries that civilian practitioners might never encounter, forcing rapid innovation and practical solutions. Ambroise Paré, a 16th century French military surgeon, made one of the most significant advances in surgical practice when he ran out of the hot oil traditionally used to cauterize gunshot wounds. Forced to improvise, he used a mixture of egg yolk, rose oil, and turpentine instead, discovering the next day that patients treated with this gentler method were recovering better than those who received the standard burning oil treatment. This accidental discovery led him to abandon cauterization in favor of ligatures for controlling bleeding, a technique that remained standard practice for centuries afterward. Paré's famous quote, "I dressed him, God healed him," reflects both the practical humility and religious framework of medieval surgery, acknowledging the surgeon's limited role in a process that remained mysterious even to its practitioners. Military medical organizations developed systems for triage and evacuation that civilian medicine would take centuries to adopt. On medieval battlefields, injured soldiers might be collected after combat and transported to field hospitals where surgeons prioritize cases based on severity and likelihood of survival, an early form of triage. These battlefield hospitals created concentrated clinical experience that accelerated learning, with surgeons performing dozens of similar procedures in short periods, developing skill through repetition. The necessity of treating multiple casualties efficiently led to standardization of techniques and instruments, creating more consistent approaches than were typical in civilian practice. Military orders like the Knights Hospitaller combined religious mission with medical care, establishing hospitals for injured soldiers and pilgrims that sometimes provided care comparable to modern field hospitals. These military medical systems represented islands of relative sophistication in a broader medical landscape characterized by inconsistency and individualized practice. The relationship between warfare and surgical innovation continued through the late medieval period as weapons technology evolved. The introduction of gunpowder weapons created entirely new categories of injuries that traditional surgical approaches couldn't address adequately. Gunshot wounds penetrated deeper than arrow or sword wounds, carried clothing and debris into the body, and caused more extensive tissue damage. Initial responses were based on the theory that gunpowder itself was poisonous, leading to treatments that often caused more harm than good, like pouring boiling oil into wounds. Over time, military surgeons developed more effective approaches based on observation and experience, learning to debride dead tissue, remove foreign materials, and manage the unique challenges of gunshot trauma. These innovations eventually transferred to civilian practice, creating one of the few pathways for systematic improvement in medieval surgery. The grim reality that war created both the need for surgical innovation and the opportunity to develop new techniques through repeated practice meant that military surgery often advanced more rapidly than its civilian counterpart. Surgical specialization began to emerge in the late medieval period, particularly in areas requiring specific technical skills or instruments. Eye surgery, particularly for cataracts, became a specialty practice in some regions, with itinerant surgeons traveling from town to town offering the specific procedure. Lithotomy, the removal of bladder stones, similarly became a specialized field, with practitioners developing specific techniques and instruments for this painful but common condition. Dental surgery remained largely separate from general surgery, practiced by dedicated tooth drawers or as one service offered by barber surgeons. This early specialization reflected the technical complexity of certain procedures and the economic reality that sufficient demand existed for practitioners to focus on a limited range of interventions. The modern phenomenon of hyperspecialization, where surgeons might focus exclusively on a single joint or organ, wouldn't emerge until much later, but its roots lie in these medieval divisions of surgical practice. The distinction between specialists and generalists created tension then as now, with specialists claiming superior expertise in their narrow domain, while generalists emphasize their broader knowledge and flexibility. The medieval approach to surgical training created a system where techniques and knowledge were passed down through generations with minimal documentation, making the history of surgery more oral tradition than written record. The master-apprentice relationship served as the primary vehicle for knowledge transmission, with apprentices learning by observation and gradually increasing participation rather than through formal instruction or texts. This system had significant strengths. It transmitted tacit knowledge that can't be easily written down, like the feel of different tissues or the subtle visual cues that guide surgical decision-making. However, it also perpetuated errors and misconceptions, as masters passed along not just their skills, but their mistakes and theoretical misunderstandings. The reliance on memory and personal transmission meant that valuable innovations could be lost when a surgeon died without adequately training successors. The most successful surgical lineages maintained continuity over generations, with techniques refined and expanded through accumulated experience. But many promising innovations disappeared with their originators, forcing subsequent generations to rediscover what had been known before. The public perception of surgeons in medieval society reflected their ambiguous status between craftsmen and healers. Unlike physicians, who maintained scholarly distance and rarely touched patients, surgeons performed visible, physical interventions that could appear more like butchery than medicine to observers. Their association with blood, pain, and physical manipulation placed them lower in the social hierarchy than physicians, despite the practical value of their skills. Surgeons were viewed with a mixture of respect for their necessary abilities and suspicion of their intimate familiarity with the body's interior. This ambivalence extended to legal standing as well, with surgeons sometimes called as expert witnesses in cases involving wounds or suspicious deaths, an early form of forensic medicine, while simultaneously being viewed with suspicion when their patients died unexpectedly. The surgeon's position on the boundary between respectable and questionable professions reflected broader medieval anxieties about the body and its violation, even when that violation was necessary for healing. Medieval surgical treatises reveal a curious combination of practical wisdom and theoretical misconception that characterized surgical knowledge of the period. Works like the Chirurgia Magna of Guy de Chauliac, 14th century, contain detailed procedural descriptions alongside explanations based on humoral theory or other frameworks we now know to be incorrect. These texts often included case histories describing successful and occasionally unsuccessful interventions, providing valuable documentation of actual practice rather than mere theory. The illustrations in surgical texts evolved from stylized, anatomically incorrect drawings to increasingly accurate depictions, particularly after the revival of human dissection in European universities. These texts weren't widely available to practicing surgeons, most of whom were illiterate in Latin, but they influenced training at universities and gradually filtered into broader practice through surgeons who bridged the academic-practical divide. The translation of these works into vernacular languages in the late medieval period made them accessible to a wider audience of practitioners, accelerating the standardization of surgical techniques across regions and creating a more consistent body of surgical knowledge. The economic aspects of medieval surgery created complex dynamics between patients and practitioners. Unlike modern surgeons who typically practice within institutions and receive regular salaries or fee-for-service payments, medieval surgeons operated in diverse economic arrangements. Some were essentially independent contractors, negotiating fees for each procedure based on the patient's means and the complexity of the intervention. Others worked under retainers for wealthy households or municipalities, providing care as needed to family members or citizens. Guild surgeons practiced within regulatory frameworks that sometimes included set fees for common procedures, creating an early form of standardized pricing. Successful surgeons in major cities could achieve considerable wealth, particularly if they secured noble or royal patronage, while rural practitioners might accept payment in goods or services rather than currency. The cost of surgery was significant, often representing weeks or months of income for average workers, making it inaccessible to many except through charity care provided by religious institutions or municipalities. This economic reality meant that many medieval people suffered or died from conditions that could have been surgically treated simply because they couldn't afford intervention. The places where surgery was performed reflected both practical considerations and social hierarchies. Wealthy patients were typically treated in their homes, with surgeons bringing instruments and assistance to the patient's bedside. This arrangement provided privacy, comfort, and reduced exposure to other sick individuals, but limited the surgeon's access to assistance if complications arose. Middle-class patients might be treated in the surgeon's home or workshop, a setting where the practitioner had all necessary tools and perhaps previous experience treating similar cases in the same space. The poorest patients received treatment in hospital wards, market squares, or other public spaces, often with minimal privacy and sometimes as demonstrations for surgical apprentices or curious onlookers. This stratification of care settings by social class would be familiar to modern patients, though the specific environments differ dramatically. The modern hospital, with its standardized operating rooms and recovery facilities serving patients of all social classes, albeit with private rooms for those who can afford them, represents a significant democratization of surgical space compared to the rigidly stratified settings of medieval practice. The intersection of surgery and religion created unique challenges and opportunities for medieval practitioners. While the church prohibited clergy from performing surgery that shed blood, the famous Ecclesia abhorret sanguine, the church abhors blood, this restriction didn't prevent clerics from studying surgical texts or even directing procedures performed by lay people. Monasteries often included infirmaries where basic surgical care was provided, though bloodier procedures might be performed by lay brothers or secular surgeons called in for specific cases. Religious orders like the Hospitallers developed considerable surgical expertise through their mission of caring for sick pilgrims and wounded soldiers. The Church's position on surgery was thus more nuanced than simple prohibition, with practical necessity often overriding theological concerns. This tension between religious restrictions and medical needs created a system where surgical knowledge and practice developed along parallel tracks. Formal, theoretical knowledge within religious institutions and practical skill among secular practitioners, occasionally converging when circumstances demanded. The development of hospitals in medieval Europe reveals the complex relationship between religion, charity, and medical care. Most hospitals were founded by religious orders or wealthy patrons seeking spiritual benefits from charitable acts rather than as dedicated medical facilities. The medieval hospital functioned more as a general refuge for the sick, poor, and travelers than as a treatment center, with spiritual care often prioritized over physical intervention. Surgical procedures were performed in these settings, but typically only when absolutely necessary, with the facility's primary mission being comfort and spiritual preparation rather than aggressive treatment. The Hospital of St. John in Jerusalem, founded by the Knights Hospitaller in the 12th century, represented an exception to this pattern, developing protocols for wound management and surgical intervention that were remarkably sophisticated for the time. This model of the hospital as both spiritual refuge and treatment center gradually spread through Europe, laying the groundwork for the modern concept of the hospital as a dedicated medical facility while retaining elements of its religious origins that persist in many hospital names and missions today. Disease theories that informed surgical practice reflected the limited observational tools available to medieval practitioners. Without microscopes to see bacteria or knowledge of cell theory to understand tissue response, surgeons relied on visible signs and philosophical frameworks to explain what they observed. The dominant humoral theory, inherited from Greek medicine, explained disease as an imbalance of the four bodily humors: blood, phlegm, black bile, and yellow bile. This framework influenced surgical approaches, with procedures often aimed at restoring humeral balance rather than addressing what we would now identify as the actual pathology. Bloodletting, for instance, was performed to reduce an excess of blood in conditions ranging from fever to madness. While fundamentally incorrect, humeral theory did encourage systematic observation and intervention, creating a framework where surgeons look for patterns and adjusted treatments based on patient response rather than working from purely superstitious or arbitrary approaches. This theory-driven observation laid groundwork for the empirical methods that would eventually replace humeralism itself. The sensory experience of medieval surgery involved all five senses in ways that modern surgical practice deliberately avoids. Surgeons relied heavily on touch to diagnose conditions and guide interventions, developing sophisticated tactile skills in the absence of imaging technologies. The feel of different tissues, the temperature of inflamed areas, and the resistance of various structures to pressure or cutting provided crucial information that couldn't be obtained visually. Smell played a diagnostic role as well, with experienced practitioners recognizing the distinct odors of different types of infection or tissue necrosis. Sound provided feedback during procedures. The grinding of bone during amputation, the patient's vocalizations indicating pain levels, or the gurgling of air in chest wounds all conveyed important information. Taste, while less commonly employed, occasionally featured in diagnosis, with some practitioners tasting urine or wound discharge to assess qualities not visible to the eye. This multisensory approach to surgery created an intimate, visceral connection between surgeon and patient that modern surgical practice, with its emphasis on sterile barriers and technological mediation, deliberately minimizes. The role of surgical assistants in medieval procedures was critical but rarely documented in medical texts, creating a historical invisibility that belies their importance. Most surgeons worked with at least one assistant, often an apprentice learning the craft, who provided crucial support during procedures. These assistants restrained struggling patients, sponged blood from the surgical field, handed instruments to the surgeon, and sometimes performed minor aspects of the procedure under direction. In wealthier households or institutional settings, multiple assistants might be employed, creating a primitive surgical team with divided responsibilities. The effectiveness of these teams depended heavily on experience working together, with long-standing partnerships developing nonverbal communication and anticipatory assistance that improved outcomes. The hierarchy within these teams was absolute, with a master surgeon directing all aspects of the procedure and assistants following instructions without question. A dynamic that persists in modified form in modern operating rooms, where the lead surgeon still maintains ultimate authority despite more collaborative approaches to surgical teamwork. The process of becoming a surgeon in medieval Europe followed various paths depending on region, time period, and social context. In areas with strong guild systems, the traditional progression moved from apprentice to journeyman to master, with specific requirements at each stage. An apprentice might spend 5 to 7 years learning the craft, gradually assuming more responsibility under supervision. The journeyman phase involved practicing independently but without taking on apprentices, often traveling to gain experience with different masters and techniques. Achieving master status typically required demonstrating skill through examination or producing a masterpiece, a particularly challenging procedure performed successfully before guild representatives. In university-influenced regions, surgical training might include formal study of anatomy and medical texts, though practical skills were still acquired through apprenticeship rather than classroom instruction. The most comprehensive training combined both approaches, with practitioners studying theoretical foundations while developing practical skills through supervised experience, an integration that foreshadows modern surgical education with its dual emphasis on scientific knowledge and technical proficiency. The surgical approach to different body regions reflected both anatomical understanding and cultural significance. Head surgery, particularly trepanation, cutting holes in the skull, was performed with surprising frequency and success, as evidenced by archaeological remains showing healing around surgical openings. This procedure addressed conditions ranging from head trauma to epilepsy to mental illness, based on the theory that releasing pressure or evil spirits would resolve symptoms. Abdominal surgery was approached with greater caution, as opening the abdominal cavity frequently resulted in fatal infection. Limited procedures like hernia repair or bladder stone removal were performed, but extensive exploration of the abdomen was rare and usually fatal. Chest surgery was similarly limited, with external wounds treated but internal interventions rare except in desperate circumstances. Limb surgery, particularly amputation, was relatively common and sometimes successful, with techniques for controlling bleeding and managing the stump that produced survivable results. This regional approach to surgical intervention, with some body areas considered reasonably accessible and others virtually untouchable, created a patchwork of treatable and untreatable conditions that shape patient expectations and surgical practice. The role of women in medieval surgery represents a complex interplay of gender norms, practical necessity, and occasional exceptional cases. While formal surgical training through guilds or universities was generally closed to women, practical surgical skills were often part of women's domestic medical knowledge, particularly in rural areas where professional practitioners were scarce. Women routinely managed wounds, set bones, and assisted with childbirth as part of their household responsibilities. Some women practiced as midwives with significant surgical capabilities, performing episiotomies, removing retained placentas, or even extracting dead fetuses when necessary to save the mother. Procedures requiring genuine surgical skill. Rare cases of women practicing as professional surgeons are documented, typically widows who continued their husbands' practices or daughters trained by surgeon fathers. These exceptions typically required special permission from guilds or authorities and often faced restrictions on the types of procedures they could perform. The most famous case is Jacoba Felici, who was prosecuted in 14th century Paris for practicing medicine and surgery without a license, despite testimonials from patients attesting to her skill and successful treatments. Her case highlights both the existence of female practitioners and the institutional barriers they faced. The development of surgical techniques for specific conditions shows the gradual accumulation of practical knowledge despite theoretical misconceptions. Hernia repair, for instance, evolved from primitive approaches involving castration, based on the incorrect belief that hernias were connected to the testicles, to more sophisticated techniques preserving reproductive function. Cataract surgery progressed from crude couching procedures that pushed the clouded lens aside to more refined techniques that minimize damage to surrounding structures. These improvements typically resulted from individual innovations by practitioners who observed problems with traditional approaches and experimented with modifications. The lack of systematic documentation meant that such innovations spread slowly and unevenly, with significant regional variations in technique for the same procedure. Some communities might benefit from an advanced approach, while others continued using older, less effective methods simply due to geographical or cultural isolation. This pattern of localized innovation, followed by gradual, uneven diffusion, characterized much of medieval surgical progress, creating a landscape where the quality of care depended heavily on whether a patient happened to live near a particularly skilled or innovative practitioner. Medieval surgeons developed surprisingly sophisticated approaches to wound management despite their limited understanding of infection. Wounds were categorized according to their appearance, location, and cause, with different treatments prescribed for each category. Clean, incised wounds might be sutured closed using materials ranging from linen thread to ant pincers, used as natural staples in some regions by placing the ant so it bit the wound edges together, then removing its body and leaving the head in place. Contaminated or jagged wounds were typically left open to drain, based on the observation that premature closure often led to festering and spread of corruption through the body, a primitive recognition of the dangers of sealing infection within tissues. Wound dressings incorporated materials with genuinely beneficial properties, honey with its antibacterial effects, wine as a mild antiseptic, or certain molds containing natural antibiotics. The influence of different medical traditions created regional variations in wound care practices, with Islamic approaches generally emphasizing cleanliness and gentle handling of tissues, while European traditions might focus more on aggressive drainage and cauterization. These different philosophies produced significantly different outcomes, with patients treated according to Islamic surgical principles generally enjoying better survival rates and less post-traumatic deformity than those treated by typical European methods. The archaeological evidence of medieval surgery provides a fascinating counterpoint to textual sources, sometimes confirming and sometimes contradicting written accounts of surgical practice. Human remains from medieval cemeteries show evidence of numerous surgical interventions, from healed trepanation holes to amputated limbs with signs of long-term survival. These physical findings confirm that some procedures were performed with sufficient skill to allow recovery, even in an era before antibiotics or anesthesia. Skeletal evidence also reveals procedures rarely mentioned in surgical texts, suggesting a broader range of interventions than the written record indicates. Grave goods occasionally include surgical instruments buried with practitioners, providing physical examples that can be compared with illustrated texts. In some cases, these archaeological finds reveal more sophisticated or specialized tools than contemporary documents describe, suggesting that practical surgical knowledge sometimes exceeded what was formally recorded. The combination of textual and archaeological evidence creates a more complete picture of medieval surgical practice than either source alone could provide, revealing both the limitations and the surprising sophistication of early surgical interventions. The relationship between surgeons and patients in medieval Europe operated on fundamentally different assumptions than modern doctor-patient relationships. Without the concept of informed consent, surgeons determined necessary interventions based on their assessment rather than patient preference. Explanations were provided not to obtain permission, but to prepare the patient psychologically and ensure cooperation during the procedure. This paternalistic approach reflected broader social hierarchies, with the surgeon's authority over the patient mirroring other power structures in medieval society. Despite this imbalance, the relationship wasn't purely authoritarian. Successful surgeons recognized the importance of patient trust and cooperation, developing bedside manners that inspired confidence and provided psychological support. The best practitioners combined technical skill with interpersonal abilities, understanding that the patient's mental state affected physical outcomes. This integration of technical and interpersonal aspects of care foreshadows modern understanding of the psychosocial dimensions of surgery, where patient confidence, reduced anxiety, and positive expectation demonstrably improve surgical outcomes. The medieval surgical understanding of pain management reveals sophisticated psychological insights despite limited pharmaceutical options. Surgeons recognized that pain perception was influenced by factors beyond the physical stimulus, including the patient's expectations, emotional state, and understanding of the procedure. Preparation for surgery often included psychological elements designed to reduce anxiety and build confidence, from reassurance about the surgeon's skill to religious rituals that provided spiritual comfort. Distraction techniques were employed during procedures, with assistants engaging patients in conversation or applying pressure to other body areas to divert attention from the surgical site. The timing of procedures considered psychological factors as well, with some surgeons preferring to operate without warning to prevent anticipatory anxiety, while others provided detailed explanations to reduce fear of the unknown. These psychological approaches to pain management reflected practical wisdom gained through observation rather than theoretical understanding of pain pathways, demonstrating that effective pain control strategies can develop even in the absence of formal psychological theories or potent analgesics. The presence of family members during medieval surgery created a fundamentally different surgical environment than the closed operating rooms of modern practice. Family typically remained present throughout procedures, providing both practical assistance and emotional support. They might help restrain the patient, sponge blood, or hand instruments to the surgeon while simultaneously offering encouragement and comfort to their suffering relative. This arrangement provided benefits for all involved. The patient received psychological support from trusted individuals, The family maintained control and oversight of the process, and the surgeon gained additional assistance while being observed, creating accountability for their actions. The practice also facilitated knowledge transfer, as family members who participated in surgical care gained practical experience they could apply in future household medical situations. This integration of family into surgical practice stands in stark contrast to modern approaches, where family is typically excluded from operating rooms and may not even be present in the medical facility during procedures. A separation that increases professional control and sterility at the cost of patient psychological comfort and family involvement in care. The medieval approach to surgical failures demonstrates how practitioners maintain confidence and professional identity despite high mortality rates. When patients died following surgery, various explanatory frameworks shifted responsibility away from the surgeon's skill or technique. Religious explanations framed death as divine will or predetermined fate, placing the outcome beyond human control. Humoral theory provided medical explanations, attributing failure to the patient's constitutional weakness or imbalanced humors rather than to the intervention itself. Social explanations focused on patient compliance, with failures blamed on improper postoperative care or failure to follow instructions. These frameworks protected not just the surgeon's reputation, but their psychological ability to continue practicing despite regularly experiencing patient deaths. Without these protective attributions, the emotional burden of frequent failure might have rendered surgical practice psychologically unsustainable. Modern surgeons employ similar cognitive strategies, though within different explanatory frameworks, attributing deaths to disease severity, comorbidities, or statistical inevitability rather than to divine will or humoral imbalance, suggesting that such protective cognition may be necessary for continued function in professions where failure regularly has fatal consequences. The evolution of surgical ethics throughout the medieval period reveals gradual shifts toward concepts recognizable in modern medical ethics. Early medieval surgical ethics focused primarily on the practitioner's character and intentions, with virtues like compassion, honesty, and piety considered essential for ethical practice. As surgery became more professionalized through guilds and universities, ethical frameworks expanded to include concepts of competence and proper training, recognizing that good intentions without adequate skill could cause harm. By the late medieval period, some surgical texts addressed questions of appropriate case selection, suggesting that surgeons should avoid interventions unlikely to benefit the patient, an early version of the modern principle of beneficence. The concept of truth-telling emerged as an ethical consideration, with debates about whether surgeons should honestly disclose poor prognosis or maintain hope even in dire circumstances. These medieval ethical discussions laid groundwork for modern principles like non-maleficence and respect for patient autonomy, though these concepts wouldn't be fully articulated until centuries later. The evolution of surgical ethics reflects broader cultural shifts from virtue-based ethical frameworks toward more principle-based approaches, a transition that continues in modern bioethical debates. The role of charisma and performance in medieval surgery created dynamics that modern medical practice attempts to minimize but cannot entirely eliminate. Without objective measures of surgical skill or standardized training, patients relied heavily on the surgeon's reputation and demeanor when selecting practitioners. Successful surgeons developed personas that inspired confidence, often combining authoritative knowledge claims with theatrical elements that impressed potential clients. Some cultivated distinctive appearances or mannerisms that made them memorable in competitive markets, essentially creating personal brands centuries before the concept existed in marketing literature. The actual surgical procedure incorporated performance elements designed to demonstrate skill and control, from confident handling of instruments to narration of the process that emphasized the practitioner's expertise. These theatrical aspects weren't merely marketing. They served psychological functions for both patient and surgeon, creating a shared reality where the surgeon's confidence transferred to the patient, potentially improving outcomes through placebo effects and reduced patient anxiety. Modern surgery attempts to replace charismatic authority with institutional credentialing and evidence-based practice, but elements of performance and personal charisma remain significant in patient experience and sometimes in outcomes as well. The medieval understanding of surgical recovery differed fundamentally from modern approaches, with different expectations for both process and outcomes. Recovery was expected to involve significant suffering, with pain viewed as a natural and necessary part of healing rather than as a symptom to be aggressively managed. The concept of returning to pre-surgical function wasn't always the goal. Instead, survival with reduced capacity was often considered a successful outcome for major interventions. Time frames for recovery were extended by modern standards, with months or even years considered normal for complete healing following major procedures. These different expectations shaped both patient experience and surgical decision-making, creating a framework where interventions modern surgeons would consider unsuccessful might be viewed as triumphs by medieval practitioners and patients. The gradual nature of recovery was understood through religious and philosophical frameworks, emphasizing patience and endurance as virtues, with suffering during recovery given meaning through religious interpretations rather than being viewed as unnecessary or pathological. This integration of physical recovery with spiritual and philosophical frameworks provided psychological resources for enduring the lengthy, painful recovery processes common in the pre-anesthetic, pre-antibiotic era. The intersection of surgery and social class created dramatically different experiences for patients of different statuses. Wealthy patients received care in their homes with the best available pain management and post-operative support, while poor patients might be treated in crowded hospital wards or even public spaces like marketplaces. Beyond these obvious differences in comfort and privacy, social class affected the technical aspects of surgery itself. Surgeons might take more time and care with wealthy or powerful patients, while using faster, cruder techniques for the poor. Experimental or risky procedures were typically performed on low-status patients first, with techniques only offered to the wealthy after being refined on the bodies of the poor. This pattern of innovation, where new techniques are developed on marginalized populations before being offered to privileged groups, persisted well into the modern era of surgery and remains a concern in global surgical ethics today. Despite these disparities, social class wasn't perfectly predictive of outcomes. Wealthy patients sometimes received harmful treatments due to their ability to pay for unnecessary interventions, while poor patients occasionally benefited from simpler approaches with fewer complications. The relationship between social privilege and surgical benefit was thus complex rather than linear, creating unexpected patterns of advantage and disadvantage across the social spectrum. The geographical distribution of surgical knowledge created significant regional variations in practice and outcomes. Urban centers, particularly those with universities or large hospitals, typically offered more sophisticated surgical care than rural areas, creating an early version of the urban-rural healthcare divide that persists today. Coastal regions with trade connections to other medical traditions often incorporated techniques and instruments from different cultures, creating hybrid approaches that could be more effective than isolated traditions. Mountainous regions sometimes preserved older practices abandoned elsewhere, occasionally maintaining effective folk techniques lost to more advanced areas. Political boundaries affected surgical practice as well, with different kingdoms or city-states developing distinct regulatory approaches and training systems. War zones sometimes developed sophisticated trauma surgery due to constant practice, while peaceful regions might maintain better elective surgical traditions. This geographical patchwork meant that the same condition might receive dramatically different treatment depending on where it occurred, with survival rates varying accordingly. The uneven distribution of surgical knowledge and skill created a system where location could be as significant as the nature of the condition itself in determining patient outcomes, a pattern still visible in global and regional healthcare disparities today. The interaction between surgery and disability in medieval society reveals complex attitudes toward bodily difference and functional limitation. Surgical interventions sometimes created disability through amputations or other procedures that permanently altered function, while in other cases surgery attempted to address congenital or acquired disabilities through corrective approaches. The social response to surgically created disability varied by context. A knight who lost a limb in battle might receive respect and accommodation, while a peasant with the same surgical outcome might face destitution if unable to work. Some cities and guilds provided support for members disabled through injury or surgery, creating early systems of disability assistance. Religious frameworks influence perceptions of disability, sometimes viewing it as divine punishment and other times as opportunity for spiritual growth or community charity. Prosthetics and adaptive devices showed surprising sophistication in some contexts, with artificial limbs, specialized crutches, and modified tools creating functional adaptations for those with surgical alterations. The medieval approach to post-surgical disability thus combined elements of exclusion and accommodation, spiritual interpretation and practical adaptation, creating a complex landscape of disability experience that varied dramatically by social context, cause of impairment, and available resources. The evolution of surgical concepts from antiquity through the medieval period reveals both persistent misconceptions and gradual progress toward more effective approaches. Ancient Greek and Roman surgical texts, particularly the works of Hippocrates, Galen, and Celsus, provided the theoretical foundation for medieval practice, though these works reached Europe primarily through Arabic translations that sometimes introduced modifications based on Islamic medical experience. The Byzantine Empire maintained continuity with classical surgical traditions, preserving techniques that were lost in Western Europe during the early medieval period. When classical texts were reintroduced to Western Europe through translations from Arabic sources in the 12th and 13th centuries, they created a surgical renaissance that combined recovered ancient knowledge with practical innovations developed during the intervening centuries. This complex transmission path created surgical traditions that contained elements from multiple cultures and time periods, sometimes preserving effective techniques whose theoretical justifications have been lost or misconstrued. The medieval surgeon thus operated within a knowledge framework assembled from fragments of different medical traditions, creating an approach that was neither purely classical nor entirely original, but rather a hybrid of preserved knowledge and practical innovation. The role of surgical illustrations in medieval medical texts reveals the challenges of visual communication in an era before standardized anatomical terminology or printing technology. Early surgical illustrations were often schematic rather than realistic, showing procedures through stylized representations that emphasize conceptual understanding over anatomical accuracy. Human figures might be drawn with simplified internal structures based on Galenic anatomy, which contains significant errors due to its basis in animal rather than human dissection. Surgical instruments were depicted more accurately than anatomy, reflecting the concrete nature of tools compared to the theoretical understanding of internal structures. As human dissection became more accepted in European universities, anatomical illustrations gradually improved in accuracy, though they remained idealized rather than realistic in many cases. The introduction of printed books in the 15th century revolutionized surgical illustration, allowing identical images to be reproduced consistently rather than reinterpreted by different manuscript copyists. This standardization of visual information accelerated the spread of surgical knowledge, creating common visual references that facilitated more consistent training and practice across regions. The evolution of surgical illustration thus parallels the broader development of scientific communication, moving from conceptual schematics toward observational realism as empirical approaches gradually displace theoretical frameworks inherited from antiquity. The medieval approach to surgical complications demonstrates a sophisticated understanding of wound healing despite fundamental misconceptions about causation. Surgeons recognized patterns of complications and developed preventive measures based on observation, even without understanding the underlying mechanisms. They observed that certain wounds were more prone to corruption, infection, than others and developed classification systems to guide treatment decisions. Deep puncture wounds, particularly those caused by unclean objects, were recognized as especially dangerous, leading to recommendations for aggressive cleaning and enlargement to allow drainage, approaches that actually did reduce infection risk. The dangers of premature wound closure were understood through observation, with recommendations to keep contaminated wounds open until clean healing was established, a practice that prevented the sealing of infection within tissues. Surgical texts describe the progression of wound healing in stages that largely correspond to modern understanding, from initial inflammation through granulation to eventual scar formation, though they attributed these changes to humoral processes rather than cellular activity. This combination of accurate observation with incorrect theoretical explanation created a paradoxical situation where effective practices were maintained and transmitted despite fundamental misunderstandings about why they worked. The treatment of chronic conditions through medieval surgery reveals both the limitations of pre-modern medicine and the resourcefulness of practitioners working within those constraints. Conditions like hemorrhoids, fistulas, and varicose veins were approached surgically with techniques that sometimes provided genuine relief despite the absence of anesthesia and asepsis. Hemorrhoids might be treated through cauterization or ligation, using techniques not entirely dissimilar from modern approaches. Fistulas were recognized as tunneling wounds that required opening along their entire length to heal properly, a principle still applied in modern treatment. Varicose veins were sometimes addressed through a procedure called phlebectomy, where the vein was exposed through incisions, tied off, and removed, a surprisingly modern approach. Chronic wounds and ulcers were managed through debridement of dead tissue and application of various dressings, some of which contained ingredients with genuine medicinal properties. These interventions for chronic conditions demonstrate that medieval surgery wasn't limited to emergency procedures like amputations or battlefield trauma, but included elective interventions intended to improve quality of life rather than simply preserve it. The willingness of patients to undergo these painful procedures without anesthesia testifies to the debilitating nature of the conditions they addressed. When the alternative was lifelong suffering, even medieval surgery could represent a rational choice. The treatment of traumatic injuries in medieval surgery shows both the limitations of pre-modern approaches and surprising instances of effective intervention. Fractures were generally well managed through reduction, setting the bones in proper alignment, and immobilization using splints or plaster casts made from materials like egg white and flour mixed with animal hair for strength. Some complex fractures that would challenge modern orthopedic surgeons were recognized as beyond medieval capabilities, with texts honestly acknowledging that certain patterns of bone fragmentation were untreatable. Head trauma was approached with greater sophistication than might be expected, with surgeons recognizing the importance of relieving pressure on the brain through trepanation when patients showed signs of deteriorating consciousness or seizures following injury. Penetrating chest wounds were understood to be life-threatening due to lung collapse, with recommendations for immediate sealing of the chest wall, a principle still applied in emergency medicine today. Abdominal trauma remained largely untreatable due to the inability to manage internal bleeding or repair intestinal injuries without causing fatal infection, creating a category of wounds recognized as almost invariably fatal. This realistic assessment of capabilities and limitations demonstrates a pragmatic approach to trauma that focused resources on potentially survivable injuries, while recognizing when intervention was futile, a form of medieval triage based on observational outcome data rather than formalized scoring systems. The psychological impact of surgery on medieval patients has left fewer historical traces than the physical procedures themselves, but surviving accounts suggest experiences that would meet modern criteria for psychological trauma. Patients described profound fear before procedures, vivid memories of pain and helplessness during surgery, and recurrent nightmares afterward, classic symptoms of what we would now recognize as post-traumatic stress. Without modern concepts of psychological counseling, patients process these experiences through religious frameworks, sometimes interpreting surgical suffering as purgatorial or redemptive pain that serves spiritual purposes. Community and family support provided practical and emotional assistance during recovery, with social reintegration following surgery recognized as both physically and psychologically important. Some surgical techs address the patient's mental state directly, advising surgeons to consider the psychological impact of their words and actions, an early recognition of what modern medicine would call the psychosocial aspects of surgical care. The medieval approach to surgical trauma thus combined religious meaning-making, community support, and practical coping strategies, creating a holistic response to experiences that remain psychologically challenging despite their different cultural context. This integrated approach to physical and psychological aspects of surgical experience offers an interesting counterpoint to modern surgical care, which sometimes addresses these dimensions separately despite evidence of their interconnection. The role of placebo effects in medieval surgery reveals the complex relationship between belief, physiology, and healing in pre-modern medicine. Without understanding the neurobiological mechanisms of placebo responses, medieval surgeons nevertheless recognized and utilized the healing power of patient expectation. Surgical rituals incorporated elements designed to enhance confidence in the procedure and practitioner, from impressive-looking instruments to authoritative demeanor to careful staging of the surgical environment. Treatments combined physical interventions with components that we would now recognize as primarily psychological in effect, such as prayers, incantations, or application of substances with symbolic rather than pharmacological significance. The boundary between real treatment and what modern medicine would classify as placebo was non-existent in a system that didn't distinguish between physical and psychological aspects of healing. This integrated approach sometimes produced better outcomes than might be expected from the physical interventions alone, as positive expectations demonstrably affect pain perception, immune function, and wound healing through mechanisms only recently understood by modern neuroscience. The medieval surgical approach thus inadvertently harnessed psychoneuroimmunological pathways through ritual and belief, creating a healing system that operated simultaneously on physical and psychological levels, an integration that modern surgical practice, with its sharper distinction between physical treatment and psychological support, sometimes fails to achieve. The training of the patient's family for post-surgical care represented a crucial aspect of medieval surgery rarely mentioned in formal medical texts. With no professional nursing staff or recovery facilities, the burden of post-operative care fell entirely on the patient's household. Surgeons provided verbal instructions to family members about wound care, dietary recommendations, monitoring for complications, and when to seek additional help if problems developed. These instructions created a body of practical medical knowledge transmitted through households rather than formal medical channels, with women typically serving as primary caregivers and thus developing considerable expertise in post-surgical management. Family members learned to change dressings, prepare appropriate foods for surgical recovery, recognize signs of infection, and provide basic nursing care through direct instruction from surgeons and practical experience caring for their relatives. This system of household-based post-surgical care created a distributed healthcare model where medical knowledge extended beyond professional practitioners into family networks, with expertise passing informally through communities. The effectiveness of this approach varied dramatically with the resources and abilities of individual households, creating significant disparities in post-surgical outcomes based on family situation rather than the surgical procedure itself. A pattern of inequality that persists in modified form in modern healthcare systems, where post-hospital outcomes often correlate strongly with home support situations. The medieval understanding of surgical timing reveals sophisticated observations about physiological patterns despite limited theoretical frameworks. Surgical texts advise different approaches based on patient age, with recommendations for gentler techniques and special precautions for children and the elderly, an early recognition of how age affects surgical risk and recovery. Seasonal timing was considered critical, with warnings against major elective procedures during extreme heat or cold. Practical advice in an era without climate control, when surgical infection rates likely did vary seasonally due to temperature effects on bacterial growth and healing. Astrological timing represented an attempt to systematize surgical planning, with different procedures considered appropriate under different planetary configurations. A framework we now recognize as scientifically unfounded, but which nevertheless impose a structure on surgical decision-making that may have standardized practice. Lunar cycles were particularly emphasized, with recommendations against procedures requiring significant bleeding during the full moon, a belief we now know lacks scientific basis, but which created predictable patterns of surgical scheduling. The attention to timing in medieval surgery reflects recognition of patterns in surgical outcomes that couldn't be explained within available theoretical frameworks, leading to explanatory systems that attempted to impose order on observations that seemed to vary in regular but mysterious ways. Modern surgical timing considers factors like circadian rhythms, medication cycles, and optimization of comorbidities, different variables, but a similar recognition that when surgery occurs affects how it proceeds. The archaeological evidence of surgical instruments provides tangible connections to medieval practice that complement and sometimes contradict textual sources. Excavated instruments show remarkable continuity in basic designs across centuries, with essential tools like scalpels, forceps, and probes maintaining similar forms from Roman through medieval periods. The quality of these instruments varied dramatically, from crude iron implements to precisely crafted bronze or silver tools with decorative elements, signifying their importance. Some specialized instruments discovered archaeologically don't appear in surviving texts, suggesting practical innovations that weren't documented in formal surgical literature. The materials used for surgical tools, primarily metals like iron, bronze, silver, and occasionally steel, created both advantages and limitations, with trade-offs between sharpness, durability, corrosion resistance, and cost influencing instrument design and availability. Evidence of repair and modification on surviving instruments indicates that these tools represented significant investments for their owners, maintained and adapted over years or decades of use rather than being regularly replaced. The distribution of surgical instruments in archaeological context provides insights into the spread of surgical practice beyond major medical centers, with specialized tools appearing in unexpected locations like rural religious sites or small settlements, suggesting wider distribution of surgical knowledge than might be assumed from textual sources alone. These material remains of medieval surgery provide concrete evidence of how theoretical knowledge was translated into practical tools, revealing the technological constraints and innovations that shaped surgical practice on the ground. The transition from medieval to modern surgery occurred gradually through the Renaissance and Enlightenment, with several key developments marking the path toward contemporary practice. The reintroduction of human dissection in European medical schools during the 14th and 15th centuries corrected anatomical misconceptions inherited from Galen, creating a more accurate understanding of human structure. Ambrose Parés' 16th century innovations, particularly his replacement of cauterization with vessel ligation for controlling surgical bleeding, represented a shift toward less traumatic techniques based on observational evidence rather than traditional authority. The scientific revolution of the 17th century introduced experimental methods and mechanical understandings of the body that gradually displaced humoral theory, creating new frameworks for understanding surgical pathology and healing. These developments laid groundwork for the three innovations that would ultimately transform surgery from medieval to recognizably modern practice: anesthesia, asepsis, and antibiotics, all 19th or 20th century developments. The centuries-long gap between improved anatomical knowledge and these crucial innovations created a peculiar period in surgical history where practitioners knew what needed to be done but lacked the tools to do it safely, creating an era of anatomically informed but still brutally painful and dangerous surgical interventions that bridged medieval and modern practice. The introduction of anesthesia in the 1840s marked perhaps the most dramatic single transformation in surgical experience, suddenly removing the pain that had defined surgery throughout human history. Before ether and chloroform, consciousness during surgery was unavoidable. After their introduction, painless surgery became possible for the first time. This transformation changed not just the patient experience, but the nature of surgical practice itself, allowing longer, more precise procedures without the need for speed above all other considerations. Surgeons could now take time to identify structures carefully, control bleeding methodically, and close wounds precisely rather than racing against the patient's endurance. The psychological dimension of surgery transformed as well, with patients no longer experiencing the trauma of feeling their bodies cut open while fully aware. This revolution in surgical pain management represents a clean break between medieval and modern surgical experience, creating a dividing line where surgical practice on one side remains recognizable to modern practitioners, while surgery on the other seems almost unimaginably barbaric. The development that medieval patients would have considered most miraculous about modern surgery is likely this one. Not the sophisticated technology or advanced procedures, but simply the ability to sleep through the experience and wake when it's over. The development of aseptic technique in the late 19th century, following Joseph Lister's application of germ theory to surgical practice, addressed the infection that had been the primary killer of surgical patients throughout medieval and early modern periods. The introduction of carbolic acid as an antiseptic in the 1860s, followed by steam sterilization of instruments and eventually surgical gloves, masks, and gowns, dramatically reduced post-surgical infection rates. These practices made interventions survivable that had previously been almost invariably fatal, particularly operations involving the abdominal cavity. While medieval surgeons had developed some accidentally effective antiseptic practices, like using wine or vinegar to clean wounds, the systematic application of germ theory to surgical practice represented a fundamental conceptual shift. Procedures were now designed around preventing bacterial contamination rather than managing its inevitable consequences, creating a proactive rather than reactive approach to surgical infection. This transformation extended beyond technique to the entire surgical environment, with operating rooms designed specifically to minimize contamination, a dramatic contrast to the multipurpose spaces where medieval surgery occurred. The combination of anesthesia and asepsis made surgery simultaneously less painful and more survivable, creating a revolutionary improvement in both experience and outcomes. The discovery and development of antibiotics in the 20th century completed the trio of innovations that transformed surgery from medieval to modern practice. Even with the best aseptic technique, some degree of bacterial contamination during surgery is inevitable, creating ongoing risk of infection that limited the range of survivable procedures. Antibiotics provided a safety net beneath aseptic practice, making it possible to treat infections that develop despite preventive measures. This additional layer of protection made increasingly complex surgeries feasible, allowing exploration of body cavities and organ systems that had previously remained largely untouchable due to infection risk. The transformation was particularly dramatic for traumatic injuries and emergency surgeries, where ideal aseptic conditions couldn't always be maintained, precisely the types of cases that had formed the core of medieval surgical practice. With antibiotics, even contaminated traumatic wounds or perforated abdominal organs could be treated with reasonable survival expectations, creating options for patients who would have been considered unsalvageable in earlier eras. The combination of anesthesia, asepsis, and antibiotics created a surgical environment fundamentally different from anything possible in the medieval period, making modern surgery almost unrecognizable in its safety and scope compared to its historical antecedent. The contrast between medieval and modern surgical education reveals both differences and surprising continuities in how surgical knowledge is transmitted. Medieval surgical training through apprenticeship emphasized observation, followed by graduated responsibility, with learners progressing from watching to assisting to performing under supervision before independent practice. Modern surgical residency programs follow remarkably similar patterns despite their institutional formalization, with residents still learning through the see one, do one, teach one approach that would be recognizable to medieval practitioners. The content of this training has transformed dramatically, with modern surgeons learning standardized, evidence-based techniques rather than individual masters' personal approaches. But the process of skill acquisition through supervised practice remains fundamentally similar. The greatest difference lies in the scientific foundation that precedes hands-on training, with modern surgeons spending years studying biological sciences before touching surgical instruments, a theoretical preparation unimaginable in medieval practice. The integration of scientific knowledge with technical skill creates a fundamentally different type of practitioner, capable of understanding surgical interventions at cellular and molecular levels rather than merely reproducing observed techniques. This scientifically informed approach to surgical training represents perhaps the most significant conceptual difference between medieval and modern surgical practice, though the hands-on transmission of tactile skills and judgment continues to follow patterns established centuries ago. The psychological experience of modern surgery contrasts dramatically with its medieval counterpart, creating fundamentally different relationships between patients and their surgical experiences. Medieval patients necessarily experience surgery as a fully conscious trauma, with explicit memories of pain, fear, and helplessness during procedures. Modern patients typically have no direct experience of the surgical intervention itself, with anesthesia creating an experiential gap between pre-surgical preparation and post-surgical recovery. This transformed experience changes the psychological processing of surgery from direct trauma management to anxiety about unknown processes occurring while unconscious, a fundamentally different psychological challenge. The conscious experience of pain has shifted from the procedure itself to the recovery period, with modern pain management focused on post-surgical comfort rather than intraoperative endurance. Patient expectations have transformed accordingly, with pain now viewed as a problem to be eliminated rather than an inevitable experience to be endured. The psychological preparation for surgery has shifted from bracing for inevitable suffering to managing anxiety about outcomes and recovery, creating a fundamentally different emotional landscape surrounding surgical interventions. This transformation in surgical psychology represents one of the most profound differences between medieval and modern experiences, changing not just the physical reality of surgery, but its entire psychological meaning and integration in a patient's life narratives. The institutional context of surgery has transformed from individual practitioners working in varied settings to highly standardized procedures within complex organizations. Medieval surgeons typically practiced alone or with small numbers of assistants, making independent decisions based on personal knowledge and experience. Modern surgery occurs within elaborate institutional frameworks, hospitals, surgical centers, academic medical complexes, with multiple layers of oversight, standardization, and specialization. The medieval surgeon was simultaneously diagnostician, technical operator, and post-surgical care provider. The modern surgeon is one specialist within a team that includes anesthesiologists, nurses, surgical assistants, and post-operative care experts. This institutional transformation changes not just how surgery is performed, but who holds authority over the process, with modern patients navigating complex organizations rather than individual relationships. The standardization of modern surgical practice through evidence-based protocols, checklists, and quality measures creates consistency impossible in medieval practice, but sometimes at the cost of the personalization and adaptability possible in less structured environments. The modern surgical institution, with its emphasis on reproducible processes and outcomes, represents a fundamentally different approach to surgical care than the individual practitioner model of medieval surgery. A transformation in organizational context as significant as the technological changes that enabled modern procedures. The accessibility of surgical care reveals both progress and persistent challenges in the transition from medieval to modern practice. Medieval surgery was limited by geography and economics, with skilled practitioners concentrated in urban centers and significant procedures affordable only to the wealthy or available to the poor through charity care. Modern surgery in developed countries has become dramatically more accessible through health insurance systems, public health care provision, and the geographical distribution of surgical facilities. Changes that have democratized access to procedures once available only to elites. However, global surgical access remains profoundly unequal, with approximately 5 billion people worldwide lacking access to safe, timely surgical care when needed, a disparity that creates a situation where a patient's location and economic status still determine surgical outcomes, just as they did in medieval times. Within even wealthy countries, disparities in surgical access and outcomes persist along socioeconomic, racial, and geographical lines, creating modern versions of medieval healthcare inequality. The incomplete transformation of surgical accessibility represents one of the most significant limitations in the otherwise revolutionary progress from medieval to modern surgical practice, with principles of evidence-based care unevenly applied across populations and regions. The dream of universally accessible, high-quality surgical care remains partially realized, with islands of excellence amid persistent inequality, a challenge that medieval practitioners would recognize despite the technological transformation of the field. The cultural meaning of surgery has transformed alongside its technical capabilities, changing how surgical interventions are integrated into personal and social understanding. Medieval surgery was typically a last resort when other options failed, undertaken with full awareness of its dangers and limitations. Modern surgery includes not just life-saving interventions, but quality-of-life improvements, cosmetic enhancements, and preventive procedures, applications unimaginable in earlier eras. This expanded scope has changed surgery's cultural significance from desperate intervention to routine health care, with elective procedures now commonplace where once only emergency operations were justified. The relationship between surgical intervention and personal identity has transformed as well, with modern reconstructive and cosmetic techniques allowing modifications to appearance and function that medieval patients could only dream about. Surgical scars, once inevitable markers of survival, can now often be minimized or hidden, changing their social meaning and visibility. The integration of prosthetics and implants creates possibilities for post-surgical function that extend beyond natural recovery, allowing capacities that medieval practitioners couldn't have conceived. This transformation in what surgery means, not just survival, but enhancement, not just necessary intervention, but optional modification, represents a fundamental shift in its cultural position, from dreaded last resort to routine healthcare option, and sometimes even desirable improvement. The modern patient considering surgical options inhabits a conceptual world unrecognizable to their medieval counterpart, not just in terms of safety and comfort, but in the very meaning of surgical intervention itself. The future of surgery suggests both continuity with modern practice and transformations that may make current approaches seem as primitive to future observers as medieval surgery appears to us today. Robotic and minimally invasive techniques continue the trend toward reduced trauma and faster recovery, potentially eliminating the need for large incisions and direct manual manipulation of tissues. Genetic and cellular therapies may eventually replace some surgical interventions entirely, addressing conditions at molecular levels rather than through physical restructuring. Virtual and augmented reality technologies are already transforming surgical training and planning, allowing practitioners to rehearse procedures on digital models before touching patients. Artificial intelligence applications for surgical decision-making and intraoperative guidance suggest potential shifts in the role of human judgment in surgical practice. These emerging technologies point toward a future where surgery may become less invasive, more personalized, and increasingly integrated with non-surgical therapeutic approaches, trends that would make even modern surgery seem crude and traumatic by comparison. Just as medieval practitioners could not have imagined anesthesia, asepsis, and antibiotics, current surgeons likely cannot fully envision the transformative technologies that will redefine their field in coming centuries. The constant evolution of surgical practice suggests that what seems miraculous today may become routine tomorrow, and what appears state-of-the-art now may eventually be viewed as primitive. A humbling perspective on even our most advanced current capabilities. So, there you have it. A journey through the blood-soaked, infection-ridden, pain-filled world of medieval surgery. The next time you're sitting in a sterile waiting room, scrolling through your phone while waiting for your minor outpatient procedure, remember that your medieval counterpart would be downing their last drink, making peace with their god, and wondering if they'd still be alive by sunset. Modern patients complain about hospital parking fees and insurance paperwork. Medieval patients worried about surviving long enough to develop an infection that would kill them next week instead of bleeding out on the table today. If there's one thing to take away from this grisly historical tour, it's that timing is everything. The difference between you and a medieval patient isn't courage or pain tolerance. It's simply the good fortune to be born in an era with anesthesia, antibiotics, and surgeons who wash their hands. So next time you're nervously awaiting surgery, just remember, at least nobody's suggesting a treatment plan involving pigeon droppings and a red-hot poker. Modern medicine. It's not perfect, but it's definitely an upgrade from the medieval alternative.